Passy Muir valve use with heated high-flow oxygen therapy in tracheostomy patients. Enhancing respiratory care for tracheostomy patients. Dana Gribble, speech-language pathology clinical specialist, and I, Danielle Hardy, clinical respiratory specialist in adult services at ECU Health, have collaborated together to bring education to our teams. This presentation aims to educate respiratory therapy staff on the safe and effective use of the Passy Muir valve in conjunction with heated high-flow oxygen therapy for tracheostomy patients. By the end of this session, participants will understand the rationale behind combining PMV with high-flow oxygen therapy, learn the step-by-step setup process, and review institutional policy updates that define interdisciplinary roles between speech-language pathology and the respiratory care practitioner. Objectives include understanding evidence-based benefits of Passy Muir valve with high-flow oxygen therapy, identifying safety considerations before initiating the therapy, and mastering equipment setup and flow settings, and applying policy guidelines for collaborative care. This knowledge will empower respiratory therapists to confidently implement Passy Muir valve with heated high-flow oxygen therapy, ensuring patient safety, optimizing communication, and supporting successful weaning from mechanical ventilation and hopefully tracheostomy. So why combine Passy Muir valve with heated high-flow oxygen therapy? Weaning patients from mechanical ventilation and tracheostomy is a complex process requiring restoration of the upper airway airflow and humidification. The Passy Muir valve allows expiratory airflow through the upper airway, enabling speech and improving swallowing, and promoting laryngeal rehabilitation. However, prolonged Passy Muir valve use without humidification can lead to dry mucosa and thickened secretions, increasing the risk of mucus plugging and discomfort. Heated high-flow oxygen therapy delivers active humidified gas at high flow rates, reducing secretion viscosity and maintaining mucosal integrity. Combining Passy Muir valve with heated high-flow oxygen therapy provides continuous humidification while preserving the benefits of the Passy Muir valve, potentially extending safe usage periods and improving patient tolerance. Clinical data and the benchtop experiments indicate that this combination is well tolerated and safe when proper equipment and protocols are followed. Although large randomized control trials are still lacking, this approach supports early cuff deflation, communication restoration, and efficient weaning from mechanical ventilation. Pre-treatment assessment and equipment. There are some safety considerations when considering Passy Muir valve with heated high-flow oxygen therapy. Before initiating, ensure the patient is awake and alert, or conduct a thorough upper airway patency assessment. The tracheostomy cuff must fully be deflated to allow exhalation through the upper airway. Use of an adapter with an appropriate size side holes to prevent high pressure buildup, and confirm all the equipment is designed for heated high-flow oxygen therapy. Acceptable devices include a standalone heated high-flow oxygen therapy unit or ventilators set in high-flow mode equipped with pressure release valves and occlusion alarms. Assess secretion management capability and suction oral, tracheal, and subglottic secretions before cuff deflation. Explain the procedure to the patient, including expected changes in the airflow and potential coughing to reduce anxiety. These steps minimize risks such as air trapping, CO2 retention, and aspiration, ensuring safe initiation of therapy. Attachment and flow configuration. Respiratory care practitioners will work along our colleagues in speech-language pathology. The process begins by suctioning secretions from the mouth, tracheal cannula, and subglottic port if applicable. After cuff deflation, attach the Passy Muir valve designed for inline use to the approved tracheostomy tube using the approved high-flow adapter shown in B. Note that A is just a backup. Fenestrated tubes are not required, and inner cannulas can remain in place if compatible. Ensure the adapter fits securely and maintains an open system to prevent dangerous pressure buildup. Connect the heated high flow device, verifying correct tubing and adapter placement. Initial high flow settings should range between 40 to 60 liters. For optimal humidification, adjust temperature and flow for comfort, noting that humidification decreases at lower temperatures. FiO2 should be guided by the ventilator settings. If desaturation occurs, increase flow before adjusting FiO2. Suspend the high flow therapy utilizing the one-way valve during nebulization. This means remove the Passy Muir valve to prevent malfunction of the valve. These steps ensure effective humidification, patient comfort, and safe oxygen delivery. This image illustrates the required aqua signage for the Passy Muir valve use with the OptiFlow. Signage must be clearly displayed at the bedside, including the patient's name, the respiratory care practitioner, and the speech-language pathologist's evaluation date for reference. Before starting therapy, the tracheostomy cuff should be fully deflated and the tracheal suction be performed. The OptiFlow system is attached using the aqua valve adapter and the tubing connected. The patient is encouraged to speak, and tolerance is closely monitored. Utilizing pulse oximetry, if oxygen saturation drops below 90%, the valve should be removed. According to policy, the patient requires close supervision during initial therapy, with both the respiratory care practitioner and the speech-language pathologist evaluating the patient for at least 30 minutes. The valve should be removed when the patient is sleeping and replaced if not tolerated. Proper signage helps prevent misuse and ensures all staff are aware of these safety protocols. Speech-language pathology and respiratory care practitioner collaboration. Institutional policy mandates collaboration between speech-language pathologists and respiratory care practitioners for Passy Muir valve evaluations. Orders for PMV assessment include communicative and cognitive evaluation and valve tolerance testing. The speech-language pathologist confirms medical appropriateness and coordinates with the respiratory care practitioner and nursing staff. During heated high-flow oxygen trials, respiratory care provides suctioning while the speech-language pathologist deflates the cuff and places the Passy Muir valve, followed by the adapter attachment and resumption of the heated high-flow oxygen therapy. Both professionals monitor patient stability, vocal quality, and secretion management during a minimum of 30-minute trial. Upon successful completion, an education sign is posted in the patient's room indicating clearance for PMV use, and a safety tag is applied to the cuff pilot line. These procedures ensure interdisciplinary accountability, patient safety, and adherence to best practices for communication and airway management. Common issues and maintenance. Oxygen saturation decreases after initiating heated high-flow oxygen therapy with the one-way valve. Increase the flow rate before adjusting the FiO2 to prevent room air dilution. Also, ask your patient to take a few deep breaths. Address patient discomfort or coughing by reassuring and encouraging secretion clearance. During nebulization, remove the Passy Muir valve and temporarily suspend heated high-flow therapy with the one-way valve to prevent the valve malfunction. Clean the high-flow oxygen therapy system per manufacturer guidelines and rinse the Passy Muir valve daily in soapy water, allowing it to air dry. Contraindications include partial upper airway obstruction, inability to manage secretion, and lack of alertness. Diligent monitoring and adherence to cleaning protocols reduce infection risk and ensure equipment longevity. These troubleshooting strategies maintain therapy effectiveness and patient safety throughout the weaning process. Clinical outcomes and recommendations. Clinical data from 124 patients treated with heated high-flow oxygen therapy utilizing the one-way valve demonstrated high tolerance and no adverse events attributable to therapy. Benchtop experiments confirmed that proper adapters maintain pressures below 4 centimeters of water pressure, while omission of adapters or incorrect setup can result in dangerously high pressures. High-flow oxygen therapy with a one-way valve offers advantages over just the standard Passy Muir valve use by providing continuous humidification, reducing secretion-related complications, and supporting extended Passy Muir valve use. Although pressure support is minimal and restoring physiological PEEP and humidification are critical benefits, current evidence supports safe implementation when protocols are followed. But larger randomized trials are needed for definite guidelines. Key takeaways: always use correct adapters. We have this adapter and it is actually supplied by the speech language pathology team for the aqua valve. Monitor the airway patency and collaborate with your speech language pathologist, and follow cleaning and safety protocols to optimize patient outcomes. Summary. In summary, combining Passy Muir valve with heated high-flow oxygen therapy for tracheostomized patients enhances communication, airway humidification, and overall comfort during weaning from mechanical ventilation. This approach is safe when proper equipment, flow settings, and interdisciplinary protocols are applied. Respiratory therapists play a pivotal role in setup, monitoring, and troubleshooting. We need to work closely with our speech-language pathologists to ensure patient safety and success. Staff are encouraged to apply these principles in clinical practice and engage in ongoing education to maintain competency. Questions and discussion are welcome to clarify procedures and address practical challenges encountered during implementation.